I promised you guys I would give you my CIMT results, and here they are. Honestly, I'm pretty disappointed, but let's walk through them all and I will show you all the nitty-gritty details. If you are new here, I am Dr. Lily Johnston. I'm a board-certified vascular surgeon, but I specialize in cardiometabolic prevention, so hopefully you will never need me as a surgeon. What I'm going to do is take you through all of the images that I acquired during the scans, explain them to you like I explain them to every client who comes to get a CIMT with me. Then we'll go over the report, the results, how we interpret that, and what we're going to do about them. So this first picture here is taken on the right side. That's the R in R5. My feet are to the right of the screen. My head is to the left. Blood is flowing right to left, upway towards the brain. And the big black piece here, that is the common carotid artery. You can see that it starts to get just a little bit bigger here. It starts to expand. That is where the artery splits or bifurcates. It becomes the external carotid artery, which feeds the face and neck, and then the internal carotid artery, which goes up to the brain. For anybody who ever has narrowing blockage or needs procedures or operations on the carotid, the bulb and the internal carotid are where we do those procedures and operations to clean that stuff out or put a stent in to trap the plaque and keep it from going up to the brain. But what we're looking at here is the intimal medial thickness, the IMT. Now, I've talked a lot on this channel about how we get a really precise measurement. And you can imagine that we're looking longitudinally at the artery, but it's a three-dimensional structure. This is a two-dimensional picture, right? It's one snapshot of the entire back wall of that artery. So in order to get the most precise estimate, we're actually going to take three different angles of pictures so that we have multiple aspects of the back wall to image from, and those measurements will be averaged. So the R5 image that we take, that's the very first picture, is taken from about a 45-degree angle off the front of the neck. And what we're looking at is the top of this thin gray line, what separates the black from the gray. So this right here, top of the thin gray line, to the top of the bright white line. What we're measuring there is the intima and the media. The adventitia, which is the outer layer of the artery, is that bright white. So it's just this thin little layer right in here. That's all we're measuring. On this picture, these little plus signs, that just is where I'm making a note for the image interpreters that this is about where the bulb starts. So they're going to take measurements only to the right of this marker here, and they'll make 100 measurements off of this one image. Then I'm going to take a second image, same general picture. Now this is R2. So I'm going to angle the probe of my ultrasound and get a steep forward angle from the front of the neck to get a different piece of the back wall of the artery here. This one always looks just a little bit thinner because of the angle. Again, we're going to take 100 measurements from this picture here. We're going to take a third image from the back side of the neck. The R8 picture comes back under the muscle here called the sternocleidomastoid. This one always just looks a little bit thicker. This is totally normal and how all of the images look. But again, we'll take 100 measurements from this image as well. The right-sided images will then get averaged with the same pictures on the left, which I will show you. That is how we generate the IMT number that comes out in the report. So when we go over that, I'll tell you'll remember having looked at all these images to see where this comes from. Now, when I go through pictures with clients right after their scans, I tell people, I can't tell you whether your IMT is going to be, abnormal for your age or not, because we are measuring this down to hundredths of a millimeter. When it's really, really badly abnormal, I can usually tell, and sometimes I'll make that call in the moment. But by and large, I will wait on the IMT measurement. And again, I wouldn't have been able to tell what my IMT had done, from 2 years ago till now, or whether this looked thick or thin for my age, really. So, I'm not going to speculate here. I know what the report says, but we'll wait for that. What we're going to go to next is the pictures of the common carotid artery. This is where they'll take the maximum IMT reading. That's what this arrow denotes. is what I think is the most thickened area of the common carotid. And then we're going to go looking for plaque. We are now moving up a little bit towards the head or towards the brain. So this is the bulb now. We're in center frame here. And the image is a little bit cleaner to look at. It's been smoothed a little bit because we don't need quite as much precision in the measurements here. And what I'm going to show you is this area of thickening right here in the bulb. Okay, this, as it turns out, does not measure as a plaque, and I measured it when I did when we did the test to see if I thought it was actually going to show up as a plaque, but it does look a little thickened just to the naked eye. So that bothers me a little bit. And the bulb, because again, you can see it has this more irregular bowed out shape. Flow in the carotid bulb is turbulent. It's like an eddy in a river. When we have turbulent flow in blood vessels, we create areas of decreased shear stress. It's a physics term, doesn't matter. It's not laminar flow. It's not smooth. We get these eddy currents, and that creates stress on the wall of the artery, creates areas where that endothelium or the lining of the artery wall is not as robust, and it is more prone to plaque formation. So anytime there is a branch point in a blood vessel in the artery, we are more likely to see plaque form there. So the bulb is usually the highest yield place to see either thickening or plaque when we're looking for it. So already I can tell that there's some thickening here. Now, I had a little bit of thickening 2 years ago on my scan as well, but this is a little bit of a niggling thing in my brain as we're going through these pictures. But let's keep going. When we look for plaque, we want to take a picture of the artery in 2 different orientations. So up until now, we've been looking at the artery, long ways, like the long hot dog. Now we're going to turn that 90 degrees and we're going to see it in cross section. So you can see that the whole artery is the black circle here. There's this kind of little meniscus here, right? You can see just this area, the bottom of the artery is the continuation of the circle, but there's this flat line and a little bit of stuff just sitting on the bottom here, a little bit of sediment, if you will. Again, that's that area of thickening. It doesn't look terribly soft, right? It's not echolucent, it's not black, but it's also not calcified. So this is a heterogeneous thickening, or if it were thicker, it would be called a plaque. It's not, but it's sort of medium, I would say, in its characterization. Next, we're going to go even further up in towards the brain and look at the internal carotid artery. This picture with the pretty colors is what we call a Doppler flow, and that is just a checkbox, really, for us to say there's plenty of blood flow getting up to the brain. It actually doesn't add a huge amount to the protocol or the information in this test for most patients. There are times when I will use it to help identify a very soft plaque that almost doesn't look like it's there, or to demonstrate if it's on the front wall. There are some special use cases for this, but even though it's kind of the prettiest picture here in the bunch, it doesn't add a huge amount of information to the protocol itself. There's nothing quantitative about this picture in particular, but everybody likes it because it has the pretty colors. So despite what some detractors would have you believe, there is actually adequate blood flow getting up to my brain. We will then look again for plaque. I picked the thickest portion I can see. I don't see any plaque here. You can see just this tiny little sliver of intima-media here, but that doesn't look especially thickened. This marker here just, again, denotes where that artery starts, where that split happens, so they know what's the internal and what is the bulb. So the internal on this side looks fine. Again, we'll take that picture in cross section. You can see the internal here, the external is here. No major concerns from the internal artery on this side. Okay, then we go to the left side and we do it all over again. All right, my feet are still to the right, my head is still to the left, blood is flowing this way up towards the brain. And we are again going to take this measurement from the top of the thin gray line to the top of the bright white. Take 3 different orientations, front, middle, and back, so that we get all of the back wall and can get the most accurate measurement here as we can. And again, we take one measurement of the maximum thickness of the CCA. We'll show you that on the report as well. And again, we go looking for plaque. Here, this is not quite as distinct a shape, but it again looks thickened to me here. This is not completely normal artery, but it's not quite a plaque either. I'm really not happy with how that looks. It could be thinner, and that would be nicer for me. Again, we're going to look here down the barrel. The outside wall of the artery is here. There's, again, this sort of meniscus or this sediment here that you can see within the lumen. There's plenty of flow here, right? This whole black thing is wide open. There's no narrowing. There's no blockage or stenosis. But this is the beginnings of early change. This is the beginning of plaque formation. Will it be a problem in the next 10 years? Probably not. 20 years? Probably not. But if left unchecked for 30, 40, 50 years, maybe that is going to be the thing that becomes a problem. What if this is the same process that's happening in much smaller arteries around my heart? We don't know. Again, there's nothing calcified here. People have asked me, what about a calcium score? I'm under 45 years old. For a woman, that's not very high yield. If my calcium score is 0, that is not very reassuring to me. And I, given this picture, would expect that it probably is, but that doesn't mean that now isn't the time to be making some different choices or changes in my own health to see if I can make this, prevent this from accelerating or accumulating anymore. Okay. So we went to the bulb. We're now going to look to the internal. Again, nice Doppler shot, plenty of blood flow getting up to the brain, despite popular belief. And here we are in the internal. There's no thickening or plaque here in the internal. This looks fine. And again, in cross section, here's the internal carotid artery. Right next to it is its neighbor, the external carotid artery. No concerns there. So those are the pictures. Now we're going to pop over and I'll show you the actual report and how I interpret it. So here is what you see at the top of the report that comes from CardioRisk once they have analyzed all those images we just went through. The very first thing you see at the top is this box that says patient age and arterial age. This is really where we focus our attention, and this is why even though that's green and it looks like it's okay, I'll tell you why I'm disappointed. My actual age is 42 years old. My arterial age is 42 years old. That is concordant. It should be fine. But when I had this done 2 years ago, my arterial age was about a decade younger than my chronologic age. And what that means is that there's been a significant progression in the IMT or intima-medial thickness in my arteries. And that's a little disappointing, right? Like, my health is the best it's been in 2 years, and yet I still have some progression of my IMT, more than I'm comfortable with. But let me go through those numbers and show that to you here. So arterial age is actually derived from the next number in the top right of this box that says patient IMT, 0.54 millimeters. That is also the same number from this second row down in the next table that says average CCA, common carotid artery, mean or average, IMT, 0.54. So this is the IMT number that came from those 600 measurements we talked about from those pictures, okay? That's the same as patient IMT. And the way that this converts into arterial age is based on population norms. I will show you that graph in a couple of minutes here, but just suffice it to say that this is really the number that matters. When you have serial exams through CardioRisk, they will show you what the last measurements were. So if we scroll over here to the right, you can see my last visit from 2024, my IMT was 0.47. That is not an enormous change, but it's more than 0.34 per year, basically. And that is right on the threshold of kind of an accelerated level of thickening or change. So I'm not super pleased with that. The next number that we look at when we're interpreting these results is the max region, or average CCA, common carotid artery, maximum region. If you remember the pictures when I showed you the common carotid artery, there was an arrow where I said I thought things were the thickest, and that number here is 0.67. We like for the mean and the max to be as close together as possible because it suggests that the overall surface of the artery or the walls are nice and even. There aren't big areas that are super thickened and then it gets thin again and then it gets thicker, right? Again, think of this like pavement or asphalt. You want a nice, smooth, even surface. You don't want potholes and bumps and tree roots and all kinds of stuff mucking the road up. So again, this isn't different dramatically from last time. They've both accelerated, but I was 0.12 higher in 2024. Now I'm 0.13 higher. So that difference is about the same. Everything has gotten thicker. And the best news here, which maybe I should have led with, and truly when I interpret these for patients, this is what I lead with. Plaque burden, none. Okay, so none of the areas that look visually thickened to me were measuring as a plaque. This is good. This is positive, and this is absolutely the time when you want to be detecting these changes, because this is where we have all the time and opportunity in the world to make adjustments and get another scan in 6 to 12 months and see what's happening before we ever really develop a lot of plaque, or if you have some plaque, before that plaque becomes a real problem, okay? Because plaque by itself is the closest thing we have to the enemy, but it's actually events, plaque rupture, that cause heart attack, stroke, and limb loss. And if we have some plaque, we can work really hard to stabilize it, maybe even regress it, so that we never have those types of events. The next thing I'll show you is the next section down in the report is this thing that says comments. It's full of a lot of soft text, but there are some little nuggets in here that I think are helpful if you have one of these sitting on your desk that you're looking through. So it says the following values are the largest IMT measurements found in each segment. Any measurement equal to 1.3 millimeters is defined as plaque. Okay, so the difference between thickening and plaque is 1/10 of a millimeter. 1.2 millimeters and it's just thickened. 1.3 millimeters, now it's a plaque. It seems arbitrary, but we have to draw that line somewhere. And it's much less arbitrary when you realize that the whole point of detecting this thickening is, again, to figure it out before it becomes a plaque. Because what is causing the thickening, what is causing the intima and media to get thicker is the same process that causes it to become plaque. So when you have plaque, now we're able to characterize that plaque. And what I want to show you how qualitative that is, right? Yes, CIMT detects soft plaque, just like CT angiography in the coronaries will detect soft plaque. In a CT scan, it's a little bit more granular because we have something called Hounsfield's units, which are the measurement of intensity or brightness of the pixels in a CT scan. And that allows us to really say there's like kind of soft plaque, there's really soft plaque. Ultrasound, we don't have quite that much precision in terms of how we characterize the plaque, at least for this study. There are some research-based tools that are actually very, very technical and sensitive, but for now, in this exam, what we have is soft, S, heterogeneous, H, or echogenic. And that is a decision made by the analysts at CardioRisk who look at these images. So when I was saying what I thought this deposit was sort of mixed or heterogeneous, like that's really where that comes from. And all measurements are in millimeters. So here are my measurements. These don't mean anything to you. Again, you'll see the thickest one here is in the right bulb. That's 1 millimeter thick. Everything else is 0.5 to 0.7. You can see the comments from the previous scan as well. Sometimes that's interesting and helpful, particularly if it was done by a different sonographer or in a different place. So that is the comments section. Now I'm going to wrap up by showing you how we get from the IMT in millimeters to an arterial age. This is based on population data, measurements that we have across the country, across people of both sexes, and from all age ranges. So arteries naturally thicken as we age. That's a normal phenomenon. But as we can see, sometimes the measurement is even thicker than we would expect for a normal, healthy population. So what you're looking at across the bottom of this graph is age in years. So as you move left to right, the population gets older. And then on the y-axis, top to bottom, we're seeing the thickness of the artery walls, the IMT measurements. And you'll see two lines here. Again, this is what is normal and expected for men and women. Men will have slightly thicker arteries than women across the lifetime. And the red dot is where my particular measurement falls with respect to this population average. So the last time I had this test done, my red dot was squarely below the pink line, and I felt really quite good about that. Now, my red dot is right on that pink line, suggesting that, again, my arterial age is appropriate for my chronologic age, but certainly there's been a change since the last time I had this done. And if you are sitting significantly above your line, blue or pink, then that's a sign your arterial age is much higher than your chronologic age, and there is something going on that we need to figure out so that we don't have progression of your plaque or of your disease. So the question now is, what do I do with this information? We've looked through my labs, so you guys know what is going on. My omega index is not optimal. We're going to address that. My inflammation is better than it was 2 years ago. My body composition is better than it was 2 years ago. So I find this a very confronting result, to be honest, but I will tell myself and share with you all what I share with patients, which is this is okay. We have time. This disease process takes years, decades to accelerate and create issues, right? I do not have plaque right now, for which I am very grateful. Thank you, mom and dad. That is, I think, largely due to genetics. And this thickening that's happened over the last 2 years is something that can be reversed, or at least stopped, halted, right? So I need to figure out what's going on. Even though my lipids are not wildly elevated above and beyond what would be normal, they are above what is currently recommended by guidelines. And if we're looking at the sum total of my lab results, that's really the biggest thing that sticks out to me. So we have already discussed, based on that video, the plans for an experiment to see about lipid lowering, berberine versus ezetimibe. And until then, take really good care.